is Lisa Brinkman. I'm a clinical psychologist and psychotherapist, and currently I'm working in private practice in beautiful Clonakilty, West Cork. I'm here today to talk to you about being transgendered in Ireland and the challenges and the pathways for clients and professionals. The reason why it's me who's talked to you about this is a bit about my background. So I was born in Ireland, but I grew up in Germany, and in Germany I studied clinical psychology and educational psychology, but I also was very fortunate to study sex research and forensic psychiatry at the University Hamburg, and ended up working there for a few years before my return to Ireland. So that's where I got kind of all this special extra training and knowledge and client work in the kind of sex and gender related area. So I came back to Ireland in late 2007, moved to Clonakilty in 2008. And when I arrived here, I knew I'm going to set up private practice, and I wanted to reach out to colleagues in Ireland, especially those who were working on transgender issues and intersex issues, because those were the things that I've been working on for the previous 3 years in Germany. And in Germany, we had since the 1980s the laws for transgender people being able to have their gender changed, their sex changed, their names changed, and so that's what we've been working on for years. So I was just hoping to kind of connect into other colleagues who were doing this, tapping into the centre of expertise that was, somewhere in Ireland, had to be somewhere where I could connect to, and just tell them that I'm here and just see, what they're doing and where they're at. So I started looking and looking and looking, and I didn't find anything because the centre of expertise doesn't exist in Ireland. There was no, from the professional side of things, it didn't exist. There was no university, there was no, within the HSE, a special department or anything that was dealing with in any way transgender issue, intersex issue, or anything around that. So who I did come across then was TENI, the Transgender Equality Network Ireland. So I contacted them and told them who I was, sent them a little email, got an immediate reply asking if I'd meet up with them. There was two kind of people who wanted to meet me. I said, no problem at all, came down to Clonakilty, met me, and sat down and said, you're a godsend. And I was a bit overwhelmed by that. I'm so happy you're here, you're in Ireland. There's only one other psychologist at the moment, and he's in Dublin. And you two are the only ones, so it's so great that you're here. And I was a bit overwhelmed by that because I was actually, I was pregnant, and I was just going to tone down a little bit. That's why I came to Ireland, to step out of that kind of busy clinical research life I was living in Germany. So that kind of painted the picture a little bit. At that time, and this is only 2008, there was me, who just came from Germany, and the other psychologist we're talking about is Dr. James Kelly, who came from America, an American. So again, no one within the HSE. At the time, the HSE didn't provide this. Our universities didn't train the psychologists or the counsellors at the time to have specific knowledge about transgender issues. I was going to throw the I in the intersex issues as well. I know it's not about that today, but we always keep them, lose them as well, and don't talk about them either. So that is kind of, that's my story, or my professional story coming to Ireland. I did set up private practice then, and as a psychologist and psychotherapist, I deal with any kind of emotional problem and concern. But I am especially specialised in sex and gender related problems and concern, put that out. So therefore I see a lot of clients approach me then for that. So I see people with sexual trauma, sexual problems, but then obviously a lot of transgender people as well, or people questioning their gender. And that's what I've been doing for the last 8 years in Ireland. And the thing is, and that's part of my presentation or my talk here today to you, is to show you the kind of the challenges and pathways that clients, transgender people in Ireland, are faced and face with every day, but also kind of from the professional side of view, the challenges and the pathways that we have at the moment and that we're struggling with, or that we have overcome as well. Because thankfully in the last 8 years, a lot has changed. An incredible amount has changed, especially in the last kind of 5 maybe. So again, that's what we'll be looking at today. So first of all, we have to have a look at what is transgender? What are we actually talking about? And we have to distinguish it if we're looking at it from a kind of a more social context or a very clinical medical context. In the social context, transgender means anyone who doesn't identify within the binary system of female and male. And that is, and it falls into the big umbrella term of transgenderism. So it can be someone who is born in a female body and wants to be and live as a man, identifies as being a man, and wants to live as a man and undergo all interventions and certain medical interventions to get there. But it could also mean someone who identifies as being a non-binary. This is a new term that we hear more and more recently as well. It could be someone who identifies like a biological female, for example, identifying as being a male but not wanting to undergo all surgeries. Maybe just happy to identify socially as a male but not biologically as a male. So it has a huge, it's just an umbrella term really for a huge variety of anyone who identifies as not straight male or straight female. In a medical or clinical context, psychological context, it's a bit different. When we're talking about transgender, we usually mean someone with the diagnosis of gender dysphoria. Gender dysphoria is what was formerly known as gender identity disorder, but was formerly known as transsexualism. So again, you see our terms have even changed over the last few years. So it started off as transsexualism, which described, again, for example, a man identifying as being female and wanting to be female. There was huge criticism around that term. Very understandable. It put it kind of into a sexual context. People often thought when you hear someone being transsexual that it might be perverted, or so that changed. We changed the name. The DSM changed the diagnosis to gender identity disorder, which was a huge change and a big improvement to transsexualism. But even then, we kind of stumbled over the disorder part of it. So in the recent DSM-5 that we're operating with now, we're speaking of gender dysphoria, which is the diagnosis that we use now. I'm just going to quickly, or not quickly, but just going to talk you through, or just give you the official diagnostic criteria for gender dysphoria at the moment for adults and adolescents. So it describes a definite mismatch between the assigned gender and experience or expressed gender for at least 6 months, as characterized by at least 2 or more of the following features. There's a mismatch between experienced or gender and gender manifested by primary and or secondary sex characteristics at puberty. So just the body. A persistent desire to rid oneself of the primary or secondary sexual characteristics of the biological sex at puberty. A strong desire to possess the primary and or secondary sex characteristics of the other gender. A desire to belong to the other gender. A desire to be treated as the other gender. A strong feeling or conviction that he or she is reacting or feeling in accordance with the identified gender. And the gender dysphoria leads to clinically significant distress and or social, occupational and other functioning impairment. So it sounds quite complicated, but the gist behind it is that someone experiences their biological body different to their actual gender they identify with. And they also want to change their body towards and live in the preferred gender they identify with. So what's really, really interesting about this, and to my knowledge, it's kind of one of the only diagnostic criteria that has that. Gender dysphoria is in the DSM, meaning that it is within the Statistic Manual of Mental Diseases, but we don't actually see it or view it as a mental disorder anymore, in the sense that it doesn't need to be cured. If we think of any other diagnosis we have in the DSM, if it's anxiety, if it's depression, it's in there with all its symptoms, and what we want to do is get rid of it, or it's away from the normal state. So gender dysphoria is very different. It's in the DSM, and that's where we are now over the last few years, that all psychological and the medical interventions are there to help and aid the person towards gender and sex change, and to help them through that and with that, not to kind of cure them of being gender dysphoria. It might seem completely normal and natural to you. It was in the 1980s in Germany, there was these big psychoanalytic groups and group therapy sessions to help people get rid of their gender identity disorder, or transsexuality it was called in the time, especially within psychoanalytic therapies, very strong on that. So that is, again, not that long ago. So this is quite unique. The reason why it is still in the DSM, and it has kind of moved away from the term disorder, but it's kind of still in that classification system is, and that's the rationale behind it. It's still questioned, and it's kind of critically questioned at the moment. But at the moment we have it still within the DSM because the rationale behind it is that transgender people, it will allow them access then to the system and to the professional health carers that they need, the psychological support, and then later the endocrinologists, surgeons, and everything that kind of, will be part of their journey. So for that reason, we do still have it within the classification system. But again, it is critically discussed at the moment, and different opinions on that. So maybe again, in another few years' time, in the DSM-6, it mightn't even have it anymore, or a different way of dealing with it. So if we ask ourselves the question, what does it mean being transgendered in Ireland? I would just straightforwardly say it's definitely a challenge. And maybe still a slightly bigger challenge than maybe in some other European countries. That, for example, Germany or the Netherlands, that are kind of more progressive and always have been in their way of looking and dealing with transgender people. But we do have to have a look a little bit historically at it as well. So if we look at the adult population now, with adult population, I'd say anyone from kind of their mid-20s upwards. Someone who's in their 30s, 40s, 50s, a transgender person, that means they grew up in Ireland of the 60s, 70s, and 80s. And if we think of Ireland in the 60s, 70s, and 80s, it's very different to the Ireland we know now. The 60s and the 70s and the 80s, just even being gay, being different, not be kind of in the, what the church or the normal way of living is, it's quite difficult. So until recently, and again with recently, I mean the last maybe 20, 25 years, it's been very, very difficult to be transgendered in Ireland due to the lack of acceptance within society. If we just think, I even know now from my therapeutic practice that some gay people still don't come out in Ireland. We have this huge, the big campaign, which was brilliant, and all the buzz around it. But I do know of some gay people, very rural Ireland, grown-up adults, whose parents still don't know. They may live as a gay, even be in established relationships, live together, but the parents still don't know because it would be unthinkable telling them. So that was already difficult enough. So being transgender, which is that kind of extra step more of having to explain or be maybe a boy who wants to be a girl or a girl who wants to be a man, or a boy secretly dressing up, and what happens if the mum finds out. It's a very different climate than it was, or it is today, and even today it can still be difficult. But there was also a different challenge, and that was a lack of professional knowledge and expertise in Ireland. So again, only I'd say in the last 10 years that has been sweeping in, and again it started from people coming from abroad who moved to Ireland and brought that knowledge here. And incredible work has been done, and TENI has been a really great driving motor behind it in training HSE staff, making HSE kind of the system to acknowledge this and to train more healthcare professionals dealing in primary care, and just to be able to see transgender people and help them in their transitioning. I'd just like to share two stories, just two client stories that just signify a little bit of these challenges. They are extreme, but they're certainly not the extremist, and they're certainly not like on their own. I'd have a few of them. Not, thankfully not a whole book full, but I have a few of them. One would be a good example for the lack of acceptance within society. So one of my clients is in his mid-40s, still living as a male, but feels as transgendered. So internally, very strongly identified as being female, but just can't yet, or maybe ever, really live that, just due to the way life is. But that's always been with this person, and always cross-dressed secretly. And when this person was 15, came home from school one day, and when he arrived, the local priest was sitting in the kitchen together with his mother. And they looked quite stern, and he knew something was up straight away. What had happened was that the mother, while he was in school, had gone into his room and into the wardrobes and found women's clothes and had found stilettos. And was very surprised and shocked, and in her shock, and had called the local priest, a very Catholic, very religious family. What followed then was a 3.5-hour exorcism that was performed on this 15-year-old then in his own bedroom. And I don't need to say any more. We've all seen the movies, what actually happens in this scenario. This has left this person traumatized till today. A horrible, horrible scenario. But again, it's not the only story. But that is, and this is, no, he's in his 40s now, he was 15 then, it's not too long ago, that was what could happen if things came out. Another example, another story that kind of shows a bit of the challenges around the lack of professional knowledge is a story that happened in 2009. Another client of mine, another kind of late outcomers, transgendered, still living as male, but in all aspects of his life, but identifies as being female inside. I still talk of him as him because that's how he is in all aspects of his life. But again, has always been struggling with this feelings inside, and is married, has children, so had never talked to anyone about it before. So what happened in 2009 is he just hit rock bottom. He was very, very depressed, had always been struggling with depression throughout his life, and got to the point where he was feeling suicidal. And because he had 2 children and a wife, and he just felt he had to do something, so he admitted himself to the psychiatric ward in UCC. And just because that was his last resource, something needs to happen. And they took him in, obviously, so he self-admitted himself for suicide, ideation and depression, and that was what they were treating him then for. And he said this later to me, he kept kind of bringing up this, he had never ever told anyone yet about how he actually really felt. So while he was then on the ward, he felt like he really needs to let this out now, because this is what has led him to this place. So in one of the kind of sessions with the psychiatrist, he told them that he actually thinks that he is a woman, and that he's always kept a secret, but he actually really feels feminine inside. As a result of this, he was diagnosed as being a paranoid schizophrenic, and he had self-admitted himself, so that means you can just leave again, whenever you want. So along with this diagnosis, he lost that right. So then he did feel that no one was taking him serious, it wasn't really helping, he wanted to get back home to his family, but he wasn't allowed to leave. They left him, or he had to stay in for another 2 weeks in the acute psychiatric ward. And the only way he was able to go out was, obviously he had to sign himself out, and he had to commit to seeing the outpatient clinic for at least 2 months every week. So thankfully in the outpatient clinic he saw a different psychiatrist, and this psychiatrist stumbled a bit over the diagnosis and his story and didn't quite see the schizophrenia here, and thankfully this psychiatrist Googled around a bit and found my name, so he rang me and asked me if I would take this person on. So again, this is a story that happened in 2009, not too long ago. I know there's great stories as well, and things go well. But again, this boils down to lack of professional knowledge and expertise that we still have in this country, or had a lot more even just a few years ago. And the consequences of this are quite dire, really. So in especially the adult trans community or cohort, you find a big number of high level of comorbidity, especially depression, but a high level of addiction as well. And many of my adult clients, alcoholism, alcohol abuse, drug abuse, at least at some point of their life, is very, very prominent. And again, we can understand it, that's some way of self-medicating their distress. Another consequence is that many of them have to live a secret life. Some of them are married, even have children, and this is completely secret, and no one knows about it and can't even know about it. If the wife found out, or the children, it would be kind of unthinkable. So they have this very secret life that is full of packed of lies, and it's really difficult, and that kind of causes another kind of huge emotional stress factor to kind of keep the secret, have that box or the suitcase of women's clothes somewhere that no one can find. Or the other consequence is that they don't have any family or relationships at all, that they're kind of, because of that, never in any way engage into intimate relationships with anyone, and kind of really recluse and live very isolated on their own, which again doesn't help in terms of depression and addiction. And the other consequences that is there, and that's what I find more in my psychotherapeutic practice, is that there's a lot of, I call it just dabbling in the cross-dressing scene. And the cross-dressing scene is alive and kicking, and has always been to a smaller or bigger extent. And what it means is that there's always been cross-dressing clubs or meet-ups that you can easily find where usually men cross-dress and have sexual interactions with each other. So for some transgender people, those were the only, or have been the only outlets where they could ever be, dress up and have that little bit of security. So you can find a little bit of that, to the point where there's sometimes even prostitution. Again, just the downward spiral of it being the only place or the only way they can express being a woman. Kind of leading them into that place as well. So just as I kind of threw up the term cross-dressing at you, I'm just going to quickly define it for you, because it's really important that we know the difference and know how to really differentiate between cross-dressing, what we call it transvestism, and transgender or gender dysphoria, what we're usually talking about. So in cross-dressing or transvestism, it's mostly ever males, hardly, or the female numbers are really significantly small, so it's mostly ever males. And the cross-dressing happens within some kind of sexual context, some kind of sexual pleasure. It can be at home on their own in part of their masturbation practice, or quite typical for cross-dressers as well, could be to meet up with other cross-dressers and engage in sexual activity. For cross-dressers, they often, the cross-dressing is often very sexualized, so even the clothes that they choose is very sexualized clothes. It can often be just the underwear, or very sexy short skirt, or very sexy high heels. A cross-dresser would seldomly just wear kind of a lady's jeans and, a purple sweater. It would have to be kind of very feminized, very sexualized. And mainly, again, I'm just using often and mainly because there's always exceptions of the rule, but mainly the person doesn't want to live as a female in all aspects of their life. It's just kind of one part of who they are, who they identify as who they are, but they have a quite strong still male identity and live as a male, and seldomly want, if they could wave the magic wand, would seldomly actually want to be a female in all aspects of their lives. The cross-dressing or transvestism from a psychological point of view, a psychotherapeutic point of view, has more kind of the quality of an addiction. If we think of being addicted to something that is kind of something we do as a stress relief, or if we have pressure, that will lead us into that kind of behaviour. So cross-dressing can have that a lot. It's something that cross-dressers do to self-soothe. It makes them feel nice and warm within themselves, and under times of stress they find themselves having to do it more, and over time have the urge to do it more and more. So it's kind of more like an addiction, or it's not, but has this more of an addictive quality to it rather than gender dysphoria. What we're looking at, it's kind of really about the identity of the person. The difficulty is that most cases are very clear. It's very clear if we have someone with gender dysphoria or if we have someone who's a cross-dresser. It's very obvious. I'd say about 70%. But there are some cases, especially again in the adult population, I'd say around 30%, and that's just from my clinical and experience in my practice. And it's not quite clear, and that's where kind of diagnostic and differential diagnostic is really, really important, and to really look into the person's story, because some transgendered adults report of sexual elements of their dressing as well. And it's part happens too, or if you take their history and talk to them, it might pop up. And some even, as I was saying earlier on, might even have had contacts of other cross-dressers in their life. So if you have a transgender person coming to you and telling them that they like to dress as females and that's something they've always done, and they've met up with other cross-dressers, and it's important that you check in. Now, where is this going? Because of course a transgender person is a sexual person, being as well, and has sexual elements to, of course, to themselves. And so it's okay for some aspects of the dressing to be slightly sexualized, or but again, as you know, when we are diagnosing as psychologists, we really have to check in a bit deeper as to where is this really coming from, and can we distinguish it being something sexual or something more to do with identity. The other challenge is that for some cross-dressers, especially the older ones, we're talking kind of, mid-50s, 60s, the sexual element of the cross-dressing decreases. It's less prominent. Whereas maybe before it was a lot about sexual, very highly sexualized, especially as they get a bit older and the libido wanes a bit. It's less of a sexual element. So we could have an older person coming to us, maybe in mid-50s, and again telling us that they cross-dress, and when they do, it makes them feel better about themselves, and they really need it. And so again, if there mightn't be a strong sexual element, but could still be someone who's more kind of in the cross-dressing kind of side of things rather than the gender identity side of things. So again, that's just kind of more from the practical point. When you're in practice and have people approaching you, telling you about that they cross-dress or that they're not quite sure, that's what you have to look at. And where sometimes it's very straightforward, but sometimes it isn't, and that's kind of been the challenge a bit for us to check in. So how do we deal with gender dysphoria right now? How do I deal with it in my practice? So the first point of contact for children, adolescents and young adults, let's say anyone kind of under 20 maybe, it's mainly, the first point of contact are mainly the parents, the friends, teachers. It's often kind of, a teacher that, the young people feel very comfortable with, or the school or college counsellors. Many cases where it was the school counsellor or college counsellor that a young person comes out to first. If there's a good relationship with the parents, it's often them. For adults, it's a bit different. Adults, mainly, when they do come out about it the first time, it can be the GP often, or just contact people like me directly because they Googled and found a name and an address. And TENE, again, just being out there online and available, obviously is a big first point or a contact point for many adults as well. So what are pathways in treatment? How do we, at the moment, deal with transgender people from a psychological point of view and medical point of view? So if someone is transgender or presents as being transgender through the first point of contact, so it's either a parent calling or you as a counsellor get have a student, or it's an adult who kind of approaches you or a psychologist themselves, the first step is to get a clinical diagnosis. So the diagnosis of having gender dysphoria. This is usually done by a clinical psychologist or a psychiatrist. Again, what I'm saying at the moment is, in Ireland, at the moment, we don't actually have standards of care for transgender people. We don't have official pathways yet. At the moment, they're being worked on in the background within the HSE, but right now we don't have them. So what we're doing, any professionals working in the area at the moment, we're leaning into what other countries are doing, and we're leaning into the WPATH, the World Professional Association for Transgender Health, what they recommend. And that's where all these pathways now that I'll be showing you are based on. So at the moment in Ireland, there is, from the legal point of view, no one is managing this. No one has put this out yet. So it is in progress. So this is mostly based on WPATH. So a clinical psychologist or psychiatrist has to make the initial diagnosis, and it takes at least 3 sessions to do that. Again, it's recommended by WPATH. That's how I work. I want to see a client at least 3 times to really get the time to take the full history, get to know the person, and get to know the person over time as well. Not just one single moment, but at least 3 different times. And 3 times would be a minimum. For some, it's really clear, because maybe sometimes they come to you and they're already quite, quite advanced in the transitioning process. And sometimes you might be the first person they've ever told about or talked openly about this. And they're, very far away from going anywhere with this yet. It's just really still a very internal process. So it takes at least 3 sessions. Sometimes it can take a lot longer before even the diagnosis becomes clear and before you put that in writing. The second step then usually is when there is a diagnosis, is that the clients want hormone therapy. They want to make that first step into changing the body towards the desired sex. So for that, they need a referral to an endocrinologist. It's brand new in Ireland. We've only been doing this now for 2, maybe 3 years. Still just in infancy, is that we're treating children as well, or preteens and teenagers. Again, when I was leaving Germany in 2007 at the time, that's what we were just doing in Germany. We just started doing that for about a year or 2 and realised we haven't pathways really for children yet, so we have to develop them and put them out. That was happening in Germany in 2007, so we're 2016 now in Ireland, so we've been doing it for the last 2 years, so we're just about there where we, other countries were again 8 years ago. But it's amazing that we are, because if we just think of it, 3 years ago, 4 years ago, 5 years ago, we didn't treat anyone under 18. So again, one of these big changes that has been happening over the last few years. So anyone under 16 needs to be referred into pediatric endocrinology services, and 16 plus goes into the adult services. The criteria for hormone replacement therapy is, first of all, established diagnosis by the psychologist or psychiatrist. And the criteria is that they have to have some form of social transitioning already. So they don't have to be out in every aspect of their lives, but they do have to already have some kind of transitioning done. They have to be out somewhere, somewhat. And there's different reasons for this. Sometimes there can be far too high hopes on the hormone therapy. So someone feels and identifies as being transgender, is always kept a secret. And as soon as I have the hormones, then I'm going to transition. Or when I have the hormones, they're going to make me female, or they're going to make me male. Whereas the actual transitioning, the coming out, needs to be embedded in that. Actually, some of that needs to happen beforehand, because the hormones only assist the transitioning process. They don't actually do it for anyone. So the person has to be somewhat out. It has to have some safe spaces where the person is out, it's known that it's transgendered, he or she, and is already exploring that new role. Often it can just start, at home. It might just be within the family or the best friends. I have many transgendered clients, young and old, who mightn't be out in school yet or at work yet because, I can't just yet, or for financial reasons, or but identify as trans, and when they're at home, and as soon as they're home, that's what they do, and they explore that role, and then it seems really right to send them on to that next level of bringing the hormones in to bring on some of those physical changes as well. Another requirement, sorry, some way the slides have slipped a bit, is a second opinion letter. So after the initial diagnosis from a psychologist or psychiatrist and the referral for hormone treatment, or the approval of hormone treatment, the person has to contact another psychologist or psychiatrist and get a second opinion letter. And it is, again, just to have another set of eyes looking at the case and confirming diagnosis. So at the moment in Ireland, if someone has a diagnosis of having gender dysphoria and has the approval for hormone treatment, they'll have those two letters. They'll also have to have another letter from another psychiatrist. And then what I also do is I also write to the GP. The GP knows about everything. They usually get their blood works done with the GP, so they don't have to do it with the endocrinologist. So they also have their lab results. And they need to take all those papers then to their endocrinologist. But when they have all that and the endocrinologist approves, kind of from a medical point of view, that the body is able to deal with the hormones and the hormone treatment, then they do usually walk away from that appointment with a prescription. So let's look at the hormone treatment. Again, this is just kind of throwing information at you, but just for you to know what we're actually talking about. When we're talking about hormone treatment for transgendered people or someone with gender dysphoria, there's two different hormones or sets of hormones that we're actually talking about. So there's the blockers and there's the cross-sex hormones. What the hormone blockers do is they stop the body from producing the sex hormones that the body produces. So we think of kind of our endocrine system, I'm just going to really simplify it, but if you think of a big machine, and for a male it kind of goes the male way, and for a female it goes the female way. So we have a biological male, and the machine goes the male way. So the hormone blockers stop the machine. So there's no testosterone in the male body anymore, or in the female body. We're stopping the estrogens and progesterones. So we're stopping the system. And then what we do then, when in the second step, bring in the cross-sex hormones, is we get the machine to go the other way. So if the machine's going this way, the male way, we stop it, and then we bring in the cross-sex hormones. So again, it's very simplified, but it helps a little bit to understand it a little bit better. For adults, the hormone blockers and the cross-sex hormones usually come together. They take both at the same time, and doesn't really make a big difference. The hormone blockers are really, really important and of significance when we're thinking about the young people and children that we're starting to treat now, because we, by law that we're leaning into, we don't treat any young people under 16 with cross-sex hormones. Cross-sex hormones do have irreversible effects to the body. So as soon as someone starts taking cross-sex hormones for a longer period of time, this person will lose their fertility. It will just have that effect on the body, and especially the testosterone. So we have a female to male transgender person. The testosterone will have such an effect on the body quite soon, and those effects will be irreversible as well. So the voice will drop, or body will change, the Adam's apple will grow. So should this person ever stop the hormones, not want to do it anymore, these things will never be undone. So again, that's why we have the rule not until the person is 16 years old. However, the hormone blockers, they can be prescribed earlier, and they're quite significant, because what they do is they would prevent that young person from going into puberty. So again, we think of this young girl, for example, a biological girl who identifies as being a boy, has a diagnosis of being transgender or gender dysphoria. And if this girl doesn't get the hormone blockers, of course she will kind of go through further puberty, her breasts will grow, and all the secondary sex characteristics, and likewise for a boy. For a boy, maybe even more, the voice will drop and grow quite large, and big hands and broad shoulders and big Adam's apple. So again, if we bring the hormone blockers in, it will stop these children from going through puberty, or for going through puberty even more. It gives them a little bit of time to stop that, and then when they are 16 and they have been in another 2 years of therapy and counselling and their parents and the family, and if it then still seems the right thing to do, and there's really the path they're going, then the cross-sex hormones can come in and make the whole transitioning process for them a lot easier, because they won't have to deal with all the maybe surgeries later on to undo or some of the effects that puberty sadly brought on for them. So it was highly controversial, highly discussed. It took a long time in Ireland to get to the point where we are actually treating younger kids, younger teenagers this way. But it's great that we are. And at the moment, the endocrinologist, and again, I'm talking the endocrinologist, there's only one at the moment for the adult services, and we have Cromlin at the moment in Dublin for the children, and just recently a paediatric endocrinologist here in Cork and UCC kind of came on the scene. So we've only got 2 paediatric endocrinologists, and at the moment they only really accept referrals from psychologists or psychiatrists. I have people who sometimes have to travel all the way from, Limerick or Galway or so to see me. They see me privately. I know at the moment there are things within the HSE that are there, and thankfully there are, and there are more people who are doing it. But then often with the HSE, you've got waiting lists as well, so we're not quite optimal there yet. But anyway, just think of it. Some people have to, go all the way to see a psychologist and pay, a psychologist's fee, and so that's difficult. Of course, you can understand that. But surprisingly, and sometimes it surprises me myself, my experience is that often there's a huge relief. I often have, clients saying that when they finally have the letter, they're really happy about it. It's as if they have this proof, this is really recognized. I have gender dysphoria. I'm not perverted. I'm not mentally ill. I'm not just cross-dressing, in cross-dressing. So it actually gives them the feeling of legitimating who they are. So I actually find that can be, in most cases, really positive of just being kind of acknowledged. But again, there is a kind of certain unfairness about it, that they are absolutely reliant on being in the healthcare system, and that they can't self-define that. But on the other hand, it is important that, see, for a very straightforward case, it seems like the most obvious thing that we want. Want them to be able to self-define who they are and have the right to self-define. And in a very obvious case, it's very obvious, and it seems, the right thing to do. But there are some cases that are not obvious, or are not easy, or there's lots of other stuff going on as well, or there's kids involved and work involved, and so there it's actually good to have quite a strict framework that you can work through and as a professional sometimes lean into as well, to help navigate through the kind of slightly more difficult or complicated cases as well. Just think of a female to male transgender person. So we have a biological female, and just say by fluke of nature this is a female with a very large bust. So if we think that this person has a diagnosis, right, and we absolutely see this person is transgender, want this person to help aid this person being a man, the person starts hormone treatment, starts testosterone, starts growing a beard quite soon, voice drops, but still has this large bust to deal with. And we're saying, oh, well, sorry, you have to stay, be like this for another 12 months before you're eligible for surgery. It's really, really difficult, because we're asking someone to really present, male in one way, because that will happen, the beard will grow and all that, but then also to have these really, and I just make it could be small busts as well, but it's just, just again, to simplify things. So those are cases where we really, really have to kind of question again and be a bit more, as a professional, really look at the case, be really individual, and then really base our recommendations and see to move around things as well. But that will always happen. So there'll be cases where it might really make sense to bring the hormone treatment and surgical treatment quite close together, especially in female to male when it comes to top surgery. And there'll be other cases where you might really have to space it out, just because the person isn't even emotionally ready yet to journey into that place. So there is a little bit of leeway, and in some way that is the advantage of an Ireland, that it's not, that we're not answering to anyone yet. We're professionals, we're just leaning into pathways that in some way we have that little bit of leeway at the moment if push came to shove, that we can look at individual cases a bit more in detail. So the third step then in the pathways and treatments is the surgeries that we've already started talking about. So the surgeries we're looking at are top surgery, genital reconstruction surgery, and for the female to male can be hysterectomy if it's not combined with the genital reconstruction surgery. So those are the surgeries we're looking at. The criteria for that is hormone treatment, again for at least 6 to 12 months, 2 approval letters, and social transitioning mainly completed. The challenges in Ireland about surgery is that we don't have any surgeons with the necessary expertise to perform the top surgeries in female to male and all genital reconstruction surgeries. We don't have them, they're not here. So the male to female can have the top surgery, meaning breast implants. We do that, that's a cosmetic surgery that can be availed of here. But that's about it. The mastectomy that we think about when we think of a female transitioning to being male is not the typical mastectomy that we perform in, for example, cancer patients here in Ireland. Because we want to reduce all the breast tissue, we need to resize the areola and the nipple to make a male-featured breast and not a female breast. So at present, the only way for a transgender person in Ireland to gain or have these surgeries is to do it through the HSE overseas scheme or pay privately for it. So the HSE has an overseas scheme in place, meaning that if someone does need a surgery that we don't have the expertise for in Ireland, the HSE pays for it. We liaised with the Tavistock in England, so the HSE will pay for the actual surgery, but you still have to pay for your own travel and accommodation, or else some just choose to have private surgery abroad, depending if they can afford it or not. The legal transitioning in Ireland is, funny enough, really easy, because it's always been easy. We have always been able to change our name in this country. Everyone has always had that right. And as of last year, the Gender Recognition Act came through, meaning that as an adult, you can choose, you have the right to define which gender you identify with, and you don't need any letters or any kind of approval from any healthcare professional. So that side of things is right now actually quite accessible. So why is this relevant to you? So the reason why it might be relevant to you is because you might be the first point of contact. You might be the first point of contact for a young transgender person coming out, or being in college or university and needing someone to talk to. So in that case, you might be the one offering support and guidance, helping, checking in. You might help getting necessary appointments or guiding into the right directions of a clinical psychologist, of a psychiatrist. You might help to create a trans-friendly environment in your college, in your university, bring trans awareness to the college and university, and might be called in to liaise with staff in your college or university who are dealing with that young person, maybe even with staff that might be a bit difficult around the issue. So that might be your role, and that's where you be called in. And just the media awareness that's been around Ireland over the last few years has been incredible, and one of the results is that we see so many young people as we've never seen before. And half of my caseload is under 16 at the moment of my trans caseload, and the other ones are adults. So these are 16-year-olds. These are all going to be young people you'll be seeing in another 4 or 5 years. Maybe you won't even know about them, because they're just going to be these beautiful men or beautiful young women, and they'll just be who they are. Or maybe not. Maybe they're just still in a process of somewhere down the line. So you will definitely be seeing more and more of these young people, and might have to kind of act more and more with them and help and support them on their journey. Thank you.